Well, good evening, everyone, and welcome to another weekly webinar of the IMA. I'm Dr. Ryan Cole. For those of you who don't know me, many of you do. Tonight we're talking about the evolving nature of cancer care and cancer research and what patients need to know and may want to discuss with their medical team. The evidence obviously continues to develop. There are so many ideas out there, some of which are interesting, some of which are probably way out there, and some of which might work. But across the literature, more clinicians and researchers are paying attention to metabolism, inflammation, immune function, recurrence risk, and the perioperative window around surgery for cancer. So IMA has worked on cancer care now, and that's been part of our ongoing conversation. And we continue to contribute more and more to this important area of research, education, and patient empowerment. Dr. Paul Marik is back with us tonight to discuss what he's seeing in the literature and how that connects to updates in IMA's cancer guides and what patients and clinicians should be thinking about. So we'll touch on the importance of course, vitamin D and how to approach dosing based on starting baselines, et cetera. And we'll discuss Dr. Marik's newest guides to perioperative repurposed drugs to reduce metastases. This is expanded upon from his earlier preoperative guide to now cover the full window around surgery. So this is not about replacing standard oncology care or suggesting patients manage what they're going through alone. Definitely not. It's about helping the patient and clinician ask better questions as the research continues to develop. So, Dr. Marik, welcome. It's great to have you back.
Thank you, Ryan.
And for those of you that might be new to IMA, Dr. Paul Marik is IMA's Chief Scientific Officer and an original co-founder, as well as one of the world's most published critical care physicians. He's written extensively on inflammation, immune function, metabolic health, repurposed drugs, and integrative approaches to cancer care. His work has helped shape the IMA's cancer care resources, which are designed to support patients, families, clinicians who do want, a broader framework for asking informed questions and evaluating emerging research. So tonight we're going to cover a lot of this. We're going to see what he's seeing. We'll share what folks should be aware of and how these updates fit into the larger cancer care conversation. So without further ado, Dr. Marik, let's get into specific guide updates. I want to start with what you're seeing in the broader research on cancer, as well as looking into the literature on metabolism, inflammation, all those other things that we've mentioned. So, to start with, what themes are coming across your desk as you do this deep dive?
So, Ryan, that's a good question. And to a large extent, it depends upon the practitioner that you're speaking to. The standard oncologist still gives chemotherapy.
Sure.
And as we know, if just thinking logically, it's counterproductive because we know we need an active immune system, natural killer cells, T cells, macrophages to destroy the cancer. That's cancer surveillance. Yes, and so what they're doing with chemotherapy is completely destroying the immune system to try and kill the cancer, but usually it kills the patient and the patients get septic and all kinds of complications.
Well, as an aside, my mom had a double mastectomy 3 months ago, breast cancer, and she's 83. I tried to talk her out of the chemo. That generation tends to listen to their doctor and not their physician's son doctor. But to your point, they put her on a drug that suppressed her neutrophils, one of the white blood cells, and she's recently been in the ICU for several weeks, finally out and stable, but it was the chemo that suppressed her immune system and made her septic. So to your point, a lot of people just listen to their doctor and go on some of these toxic drugs that suppress the exact thing you need to fight off the cancer. So just as a personal story, I didn't mean to take over there. But, so your point is well taken. The immune system is what fights off cancer. And so what are you seeing in the research that
So, what's interesting is that it's a very diverse world out there, as you know, different people with different thoughts. So, I have been engaging in a discussion with an oncologist who's a real oncologist who has given up using chemotherapy. Can you believe it?
That's
He
amazing.
only does immunotherapy and immunologically based therapy for cancer.
Hmm.
And it's really an astonishing thing because I think there's a, he obviously has the independence to practice the way he wants to, and it makes a lot of sense. What I have discovered, and that's why we're going to talk about patient empowerment, and
Hmm.
patients have to understand what's going on and they need to take control. I can't say this strongly enough that, and it's hard for me to say this because I believed in the system. I was part of the system. I was the chief of critical care. You cannot trust the system.
Hmm.
Patients need to be empowered. They need to do research. They need to take control of their life. You cannot trust the physician. The old paradigm where the physician tells the patient what to do and the patient just accepts it is no longer acceptable. It should be a partnership between the two. They have a dialogue and they decide on a course of action. That's what medicine should be. And that the oncologist should be open minded enough to accept what the patient wants and has to say. So there are not many, some oncologists who will allow patients to get adjunctive, alternative therapy in parallel to what they're doing. And I think that's a good idea because it's the best of both worlds.
Sure.
What I've actually learned more recently is that there's something called metronomic chemotherapy. Metronomic chemotherapy. And basically, what it's actually very smart because what they do is instead of giving high doses of pulsed chemotherapy, which wipes out everything, they use continuous doses of low dose chemotherapy, which actually targets more the tumor environment than the cancer. And in that way, helps obliterate the cancer. And the other thing which makes it very attractive is the medication is taken orally. So
Hmm.
patients do not need to go into an IV center and get intravenous chemotherapy. So it's called metronomic chemotherapy, and it's been well established for breast cancer and for colonic cancer and many other cancers that the patients can take. Many of the nutraceuticals and repurposed drugs we suggest, but in parallel, they take metronomic chemotherapy, which doesn't have the toxicity of standard chemotherapy and it's been proven in clinical trials to be beneficial. So, in a way, it's combining the best of both worlds. They're
Hmm.
avoiding the toxicity of high dose chemotherapy, which you saw firsthand.
I
And
did.
I think it's what patients, unfortunately, oncologists get paid to do what they do. And if they deviate from the protocol, they don't get paid. So that um, they'll follow the protocol. So the Hippocratic Oath used to be first do no harm. That has changed. The new dictum is first do no harm to the bottom line. And that's basically the problem is that it's all based on what's good for the bottom line rather than what's good for the patient.
Yeah, I saw a joke in the chat, why do they put nails in the lids of coffins to keep the oncologist from giving more chemo? Which I,
Yeah. And people may not realize this is that not only do they get paid for giving the chemo, the actual administration of the chemo, they get paid for doing. So it's very financially rewarding.
right. Now, kind of to the chemo idea, are there certain cancers where you find that chemo or radiation are actually effective compared, because again, we're not saying don't use the system altogether.
Oh,
There are a lot of alternatives, but there's
oh,
certain types of
Ryan,
cancers.
you ask a really important question because
Yeah.
I think the most important thing in medicine is to individualize treatment to the patient and the disease they have.
Hmm.
There's no global approach. And the question you ask is very relevant, and some people don't get it. So there are some tumors that are very chemo responsive,
Hmm.
and patients actually do really well with chemotherapy. It doesn't mean you can't add adjunctive therapy, but chemo has a good track record. I mean, we can look at, Hodgkin's lymphoma, we can
Sure.
look at leukemias, we can look at testicular cancers. Uh,
Right. That's the one I was thinking of because that's a 90+% cure rate there.
yeah, so there are some cancers that actually respond well to chemotherapy.
Hmm.
I would always suggest that you add on, ivermectin or mebendazole or green tea or whatever, and diet. So diet is central to every single tumor. So
Hmm.
just to go back, we know this is a fact. Patient walks into the office of the oncologist and says, "What can I eat?" The oncologist says, "Doesn't matter. You eat whatever you want, chocolates, cake, Krispies." And we know that is categorically, absolutely false. And we know this from the own oncology literature that diet makes a big difference. Now, tumors are very glucose avid.
Hmm.
Some tumors, the most aggressive tumors like glioblastoma and pancreatic tumors are the most avid for glucose. So diet and glucose control is absolutely the first step, the very first step, because you are feeding the tumor with the glucose. So that must always be number one.
Hmm.
And it's a really important thing. And then,
And fasting as well, and as part of diet, fasting in some of those ways.
yes. Yeah, no. So I think, lifestyle change is so important. I mean, it sounds absurd that, oncologists want to give chemo, but lifestyle interventions, which include, diet, and it's not only how you eat, but how much you eat and when you eat. You need to have an organized approach to eating. And then there's sleep and sunshine and
Mhm.
exercise and relaxation. These have all been shown to impact the outcome of cancer. So it's not a
Absolutely.
single approach, but what I say, it has to be individualized according to the particular patient. So we were talking about mutations.
Right.
So oncologists love to take the tumor and assess it for mutations. And the mutation data bank has shown there are millions of mutations, millions. There are hundreds of driver mutations, but there are only 5 mutations that are actually druggable and treatable.
Hmm.
Now, if you have that mutation, you actually do well. But and these are specific tumors that have these specific mutations. So looking at every tumor for these mutations is pointless. And then what you do is there are certain drugs that target these mutations. There are only 5 of them, and you do it in connection with the rest of the therapy. So I think this idea of a shotgun approach has to be revised to a more individualized approach. And most importantly, it must take into account what the patient wants. What
Right.
does the patient want? What are their expectations? What's important to the patient? Because quality of life and lifestyle is really important. Many patients don't want to become neutropenic, they don't want to lose their hair, they don't want to get sick of chemo. So that has to be taken into account, and patients have the right to determine the treatment that they get.
I agree 1,000% because certain treatments, they'll say, well, gosh, this is, extended life and been shown to be effective. But then when you look at the study, it's you get 2 or 3 or 4 more months of life instead of quality of life. So I think that goes back to that individual, assessment one has to make and the shared decision making with the medical team, the doctor, the oncologist, like you said, is going to have protocols, but the individual has to decide what do they want to do in conjunction with what medicine can or can't provide.
Yeah, and patients can become educated. So this may sound weird, but I think most people have these days have access to AI.
Hmm.
And AI, to a large extent, is very accurate and gives you very good information, which can help. The more knowledgeable a patient is of their disease, the better the outcome, because
Sure.
then they understand the disease and they can negotiate treatment with the physician. If they go into the doctor's office completely clueless, then they will believe everything the oncologist tells them. But if they just do a little bit of research
Hmm.
into the kind of cancer they have and the stage they have, AI will give them some good options. Obviously, AI is not treating the patient, but it's providing knowledge. So it's a combination of knowledge, hope, and teamwork.
Hmm.
Put that together rather than this shotgun approach where the oncologist tells the patient what treatment they're going to get. And clearly, patients have an option.
Right. I want to shift gears a little bit. In terms of options. Let's discuss quickly just some of the repurposed drugs and maybe what's being studied or what's being looked at besides just the standard oncology care. With some of these repurposed drugs, what are you seeing now?
Yeah. So um, the problem is, and this is where oncologists beat the drum, is that we have a lot of experience using these drugs,
Hmm.
and we know of successes, but we also know of failures. But
Sure.
overall, we do know of patients that have done well. The problem is there are no large randomized controlled trials. And so the oncologist will say, that's all very well. There's no randomized controlled trials. It's all anecdotal. It's all, um, you know,
Small
snake
K
oil
theory.
medicine.
Yeah.
It's not based on science. It's you must dismiss it. But so for multiple reasons, that's just not correct. I
Hmm.
mean, there are thousands of patients who've been successfully treated with repurposed drugs, including ivermectin. Um, Now, there's not the same level of evidence as for some of the bigger chemo drugs, but there never will be. Just because to do a randomized controlled trial costs billions of dollars that there's no profit in it, so it's never going to happen. Secondly, to actually design such a study becomes impossible because we strongly recommend patients never take one drug alone. And there's very good metabolic scientific reason for that. And that is because cancer cells live in this tumor microenvironment and are very flexible. So if you hit them with one drug, they will change their metabolic pathway and use alternative fuels and alternative pathways.
Yeah, they're
So
great
that's
shapeshifters. Absolutely.
Yeah, so I mean, it's a fundamental concept. So that's why we do not believe in using ivermectin alone or mebendazole alone or whatever. Just because these cancer cells are very smart, they develop resistance and they change their metabolic pathways. So I've developed something called the metabolic trap, in which you target at least five different pathways, the five major pathways to prevent the cancer cell developing energy. So I
Hmm.
think that's a fundamental concept which is important. And
Yeah.
because you need multiple drugs, it becomes very difficult to do a randomized controlled trial. And
Yeah.
just by the way, the word controlled in randomized control is not an accident. The controlled means the result is controlled by Big Pharma. They control the outcome. They design the study, they execute the study, they analyze the data, they change the data, they publish the data. So it's very difficult to actually believe the results of these randomized controlled trials.
Yeah,
when they're done by pharma. Pharma has enormous financial interests.
sure. Yeah, I have a physician colleague who has myeloma. That's a cancer of a certain type of white blood cell in the bone marrow, and he's survived it for many years now. Had a recurrence about a year ago. They put him on the standard chemo, didn't work, so he put himself on mebendazole, and his M spike protein in the blood came back down to normal. He went into his oncologist a few months later, and the doc said, "Hey, wow, this is amazing." And he said, "Don't you want to know what I'm doing?" He's like, "No, it's not going to change my care."
Yeah.
And so those individual cases are very informative on many types of cancer. And to your point, though, these repurposed drugs can't be used in everything, and even mebendazole is controversial in terms of resistance pathways, damaging the liver. So for certain types of cancer, there's great evidence for that, and other types of cancer, I think one has to be careful. So again, not a one size fits all. Ivermectin, same thing. Great medicine. What dose depends on the individual, depends on the cancer. And there is a lot of observational case series, et cetera. And all good medicine starts with observation, as we know. So again, this goes to the individual and that shared decision making with a doctor that's open-minded enough to help you guide your own care.
And the other thing is it's an evolving, the science is not settled. Let's be clear. The science is not settled. We're learning all the time. I learn something new every day. And
Sure.
so it's evolving. It's really important not to be dogmatic and to realize that science is moving forward very quickly. Things are changing. We're learning new things. We have tools like AI, which allow us to do really remarkable analyses and, putting the data together, which would be very difficult otherwise to do. So it is changing. I'll give you one example, and I'm going to post this tomorrow. We used to think that you need to cycle doxycycline and mebendazole alternate months. And I got some feedback from some patients that they weren't doing so well. So I looked at the data, and in fact, what we discovered is it's fine for some patients, but not for other patients. So much like most of medicine and particularly cancer therapy, the approach has to be individualized for the specific patient and the specific cancer. And
Right.
that, I think, is becoming more important. And the same thing when you spoke about the dose of ivermectin. It must be individualized. There's no standard dose. It has to be, you start off on the lowest dose and you follow the patient. This is just common sense.
Mm-hmm.
And then depending on how the patient does, you slowly increase the dose and you cognizant of the side effects. And so it's dynamic, and it's the way it should be.
I want to talk about perioperative care in cancer and what we're seeing there. But before I do that, I want to touch on vitamin D real quick. Obviously, many people have heard us talk about that. But what are you seeing evolving in that area of research on vitamin D? I mean, I have some of my opinions that have evolved as well. So I just want to see what you're finding there.
So you ask a good question. I mean, so when we talk about vitamin D, it's completely not controversial. Although the scientific community does not like vitamin D, and although they dose patients ridiculously low, the scientific data supporting the use of vitamin D is so overwhelming. First of all, in terms of prevention, almost every single patient who develops cancer has a vitamin D level less than 20.
Mm-hmm.
And what's really interesting, there's some very good observations, is as you move north and south from the equator, so as you go further from the equator and patients have less vitamin D, your risk of cancer goes up. And there are really good studies showing if you supplement with vitamin D, you reduce your risk of cancer. Mm-hmm. This is not theoretical. This is really true. And so some people say, well, what about sunshine? Sunshine's important. There are other things in sunshine which are really important. UVA, UVB, just being exposed to sun. So the sunshine is not just the vitamin D. And it's really impossible to get really good levels of vitamin D just from sunshine. You
Yeah,
basically have to spend most of your time outdoors, half naked, in order to get adequate levels, and you're going to probably get severe sunburn. So,
I want to, can I hit on this real quick, Paul? Because this is an area obviously many know I've been doing a deep dive on. If you go out in the morning sun, so when the sun is hitting the horizon, within those first 2 hours of the sun coming up, ideally when the sun hits the horizon, your clock genes in your body turn on so many different protective mechanisms. So it sends a message through your retina to your brain, which sends another message to your skin and your vitamin A, your retinols, and all the subfractions thereof, filagrins, uracanic acid, blah, 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 blah. But it also sends a signal to your protective cancer gene family, your P53s. So that morning sunlight sets your protective mechanisms. Then when you go out in midday and you do get that UVA, UVB light, the more you do that morning protocol, the more you can stay out in the sun without burning because it upregulates your protective melanin. And I want to emphasize this point. The darker your skin type, the further north you live, the more sunshine you need because like a person from, the continent of Africa that has dark skin, that's equivalent to like an SPF 50 sunscreen. So if you have a darker skin tone and you're in a northern climate, make sure you get outside more. But you can set those protective mechanisms by getting that morning light through all the clock gene mechanisms that it sets. And then that vitamin D that you do make naturally. So maybe I do run around half naked on my farm, for a couple hours a day. But that natural sunlight, the vitamin D you synthesize from that, is converted almost immediately and lasts longer than supplemental vitamin D. And then to your point, you're absolutely right. The nitric oxide benefits, the reduced reactive oxygen species, all the other things that sunlight provides, the UVA actually maintaining or lowering your blood pressure and doing so many things metabolically in the system. Sunlight is still, I think, a medication that we overlook and perhaps don't recommend enough. So that's my soliloquy on that. So I'll let you keep going.
but you would agree that sun getting sun and being in the sun is not adequate doesn't achieve adequate vitamin D levels in all patients.
Not in all patients, but I think it goes back to the individual. So, I mean, if you came to me as a patient and, I knew your skin type and I knew where latitude-wise you lived in the world, yeah, then I could work out a protocol with you as to what your ideal would be. And in my book on light that I hope to have finished in a couple months here, I'll talk about that because it goes back to the individual. It's not the same thing for everybody. This whole idea of a protocol, what's the minimum dose I need? Well, it depends on you. So
yeah, and I think also, we can measure vitamin D levels, and I think that should be a guide to see whether your levels are adequate enough and you need some kind of supplementation.
well, and to that point too, is as we know that vitamin D level also affects your microbiome. So the better your vitamin D level, the better your microbiome, the better your immune system in terms of fighting off certain types of cancers.
Yeah. So if you want to turn to the topic we were going to talk
The
about,
perioperative, yes.
perioperative.
This is fascinating. Yeah, go for it, Paul. Because most patients, I think don't understand this, and I think this is a critical area. And I had some argument, with my mother's surgeon and oncologist. So I want to hear what you have to say here. This is important.
So this is really, really, really important. And it's astonishing to me that the medical community doesn't know about it, doesn't react to it, and doesn't treat patients according to it. Because much like vitamin D, the science is actually settled. It's not like we don't know. So the point is that if you do a biopsy, but particularly if you have surgery for cancer, what happens is you dislodge those cancer cells and you have what's called circulating cancer cells. And these cells then circulate in the bloodstream. They go through different stages. They get into the tissues and they form metastases. There's absolutely no question of doubt. There's absolutely overwhelming evidence that the act of performing surgery dislodges malignant cells into the circulation, which then years later can result in metastases. Now, one has to realize that a single cell has to divide, to form like 30 billion cells before you can detect it. So
With
it takes
scans. Yeah, with scans.
time. So that's why these metastases are seen 3, 4, 5, 10 years later. But there's absolutely no question of doubt that the act of doing a biopsy or the act of actually surgerizing a patient dislodges cancer cells into the bloodstream. You can actually measure them. You can measure before and after, measure circulating cancer cells in the bloodstream, and they go up. What is astonishing is there are very simple medical interventions which can reduce the risk of the metastatic process of developing metastases. So there is overwhelming scientific data, particularly women who've had breast cancer who taken beta blockers, propranolol, show a significant reduction in the risk of developing later metastases. And there are prospective studies that have demonstrated this. So what we're saying is that there are every single patient, can I say it more clearly? Every single patient who is undergoing a surgical procedure or surgery for a malignant tumor should receive these safe, effective drugs to reduce the risk of metastases.
And this is, I think, one of the challenges in the operative scenario is oftentimes, you'll find the lump, you'll get the scans, and then oncology says, well, let's try this, that, and the other. Let's try to shrink it for 3, 4 months, 5 months, whatever, and then we'll do surgery once it's shrunk enough. And my mindset is, well, the tumor is still growing and seeding itself. Why does oncology want to leave it there while, as you and I know, a cancer has a lot of basic subsets to it. It's a hydra, multiple heads. So you may be shrinking, the one portion of the tumor that's responding to one of those pathways you mentioned earlier. But in the meantime, the other heads of this hydra, this dragon, are growing. So this whole concept of let's see if we can shrink it and we'll just leave it sitting inside you while we wait. What are your thoughts on that?
Yeah, it doesn't make sense.
It doesn't.
Yeah. So it must be a multi-pronged approach. I think sometimes the idea, particularly colorectal cancer, of shrinking the tumor before you operate makes sense. But there's no reason why you can't simultaneously give whatever medication to try and obliterate as many cells as you can and preventing metastases. So getting back to perioperative prevention of metastases, the drugs we're talking about have been well studied both in patients and in experimental models, and these are pretty safe. So the first one is modified citrus pectin. People may not have heard of it, which is part of the
peel of an orange or a lemon.
Peel of an orange.
Yeah.
Peel of an orange, modified citrus pectin, which binds a specific protein called galectin-3. So galectin-3 is expressed on cancer cells, and it allows the cancer cell to bind to the endothelium. It allows the cancer cell to get through the endothelium. It allows the cancer cells to clump together. And so it plays a really important role in the metastatic process. So there's really good data, particularly in experimental models, if you give modified citrus pectin, which binds to galectin-3, you reduce the risk of metastases. So modified citrus pectin is taken orally. It's safe, has no side effects. So what's the problem, folks? You have this nutraceuticals stroke medication that is completely safe, has no side effects, and can reduce the risk of metastatic disease.
Yeah, and for
What's
those
the
that don't
problem?
know some of the medical terms, endothelium, that's the lining of the blood vessel. So it keeps it from getting into the lining of the blood vessel
Yeah,
and
so yeah,
keeps
what
it
you're
out of the
saying is,
plumbing, basically,
can,
keeps it out of the plumbing.
yeah, the cancer gets into the bloodstream, but then from the bloodstream, it has to survive the bloodstream and then get into the tissues.
Hmm.
And it does that by galectin-3 binding to the surface of the blood vessel and then burrowing itself into the tissues. And modified citrus pectin prevents that happening.
Hmm.
The other thing is the simple beta blocker, propranolol,
Hmm. So,
which
which is
acts.
a blood pressure medicine some people take. And so, what's the mechanism on propranolol?
Yeah, so it seems to be have an effect on the immune system because it's a stress. I mean, it acts against beta blocker, against the adrenergic system, which is part of the stress system. So it seems that the stress system activates the immune system. And so by blocking beta blockers, prevent this change in the immunological milieu the cancer cells find themselves. So it helps kill the cancer cells. And
Hmm.
there's really good data. Now, we're talking about such a safe drug. It's a really safe drug. Propranolol in a smallish dose has been shown. I mean, there's overwhelming data to reduce the risk of metastatic disease.
Well,
The
it's
only
interesting, even like actors or actresses, will use it before going on stage because it has a calming effect on some of those people with
yeah,
stage fright in a low dose, to your
yes.
point.
The only caution is the patient should tell the anesthesiologist, hey, I'm taking a beta blocker because it changes the heart rate, just so that the anesthesiologist is aware. But the
Sure.
protocols are very well defined, and these patients start modified citrus pectin and a beta blocker propranolol, 2 weeks before surgery, and they continue post-operatively. I mean, if you think about it, it makes a lot of sense because you want to prevent these dislodged cancer cells from getting into the tissues and establishing themselves. And these drugs have been proven to do this. This is not theoretical. It's
Right.
important to emphasize. There's really good data to support this.
And there are two others that I know you've looked into recently, and that's the COX-2 inhibitors as well as cimetidine. So
Yeah.
you want to hit on those real quick?
Yeah. So some things like Celebrex. So it basically is it's a COX-2 inhibitor. It doesn't affect platelets, but it affects the inflammatory milieu, particularly some of the inflammatory mediators, which are required for the tumors to, embed in the tissue. So there's good data that Celebrex, if you add it to this cocktail, reduces the risk. The only caution would be, there was this problem with Celebrex and cardiac disease.
Right.
So if patients have active coronary disease, it probably is best avoided.
Sure.
But if the patient, that's why it has to be individualized.
Absolutely.
There's no simple recipe. So, modified citrus pectin, there's no contraindication. Propranolol, a beta blocker, unless you have very severe asthma, there really is the only contraindication, or you have a very slow heart rate. Celebrex is often used and been shown to reduce the risk, but you have to be cautious in patients with heart disease.
Sure.
And the fourth one is cimetidine. So cimetidine is an H2 blocker, which was one of the very first drugs used for people with peptic ulcer to decrease acid secretion in the stomach. It's an H2 blocker. And there's really good data in patients with colorectal cancer. So this is specific for colorectal cancer. For some reason, patients who take cimetidine, and again, it affects the immune system, it affects the endothelium, it affects the adhesion molecules, that
Hmm.
cimetidine has been demonstrated in patients having colorectal surgery to reduce the risk of later metastases.
Yeah, I want to hit on that real fast because as a pathologist, we can look at the tumor under the microscope. And the adhesion molecule you mentioned, ICAM, intracellular adhesion molecule, it's like a superglue that holds the cancer cells together, and the cells of your normal cells hold you together too. The cells just basically have this Velcro that hold them to each other. But certain tumors, and we have stains that can look for that specific protein, if the tumor has lost that adhesion molecule, now you've got these free-floating cells that have the opportunity to spread. So that adhesion molecule and preventing the loss of them sticking together is important in terms of keeping metastases from happening.
Yeah, so, I'm going to make a really bold statement, and people may take offense to what I'm going to say, but I think it's medical malpractice to surgerize a patient for cancer without giving the patient these preoperative drugs to reduce the risk of metastatic spread.
And with the caveat that some patients may not be candidates for some of those drugs.
But you can, yes. Modified citrus pectin is so safe.
Sure.
It's orange peel. No one is allergic to orange peel.
And do you take with the orange peel, do you take it on an empty stomach or can you take it with food?
That's a really, 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 really good question and something I've recently learned about. It has to be taken on an empty stomach with no food and no medication.
Okay, I wanted to make sure we got that in there. Yeah.
Yeah, so that's true. So the only problem about modified citrus pectin is because of the way it works, it forms like this gel in the stomach, is that you have to take it on an empty stomach, and that means also without medication.
Mm-hmm.
But it's safe. It's very safe. Beta blockers are pretty safe themselves. So, I can't see any reason why the data is so overwhelming, why this shouldn't become standard of care. Here you have an intervention which reduces the risk of metastatic disease, which improves patient outcomes, which is very simple and very cheap. It should be standard of care. And maybe that's the reason it's not standard of care, because it's very cheap and it's very simple.
It's only like $30-40 for a whole month. So, I mean, people spend that on their morning coffee, or they spend it on other things. So it's a very safe, inexpensive therapy, especially when you're going through, a scary scenario like cancer.
And then you consider the cost of the treatment of metastasis, patients who develop metastatic disease, whether, this be to the bone or the lung or the brain. It involves complex medical interventions that are really expensive. Right, so it's highly cost effective. It's a highly cost effective intervention, which I think should be standard of care.
Sure.
And so for patients listening to this who know of somebody undergoing surgery, I think this has to be strongly considered.
And even after they've had their surgery, how long, do they keep taking it during their care?
Yes, so it must. So these cells circulate for some time after the procedure. So there are different protocols, but you need to take it for at least 3 to 4 to 6 months after the surgery.
Okay. And so these aren't like all these things you're talking about. This isn't a go home, do it yourself construct. These are things that are, fantastic ideas. They're in the literature. There's evolving evidence on these, but at the same time, it's an approach where, some oncologists will listen, like your new friend who is very avant-garde, but others won't, or the surgeons may not, but an integrative physician might, or the primary care doctor might. So how, what would you advise the patient in terms of not trying to manage this alone, but at the same time trying to get their provider to understand why one would do these things? To your point of empowerment, basically.
Theoretically, this should be the jurisdiction of the surgeon. The surgeon is performing the surgery. He knows when the surgery is being done. He should provide the patient the information and say, I would like you to take these medications for 2 weeks before I operate. Mm-hmm. That's the optimal that should happen. Now, if the surgeon doesn't feel so inclined or doesn't want to, then, obviously the patient's integrative physician or general physician can do this and should do it.
Sure.
So that's why this is where patient empowerment actually comes together. So we have a guide, which basically patients can download. There's the QR code, there's the code. They can get it from the website.
And if you
Which,
can't snap a picture of the code or grab the code, folks, go to imahealth.org and it'll be in the cancer care section of imahealth.org.
and Ryan, what's important is there are all the medical peer-reviewed medical references.
Mm-hmm.
So, this is not snake medicine stuff that we're making up. This is all in peer-reviewed medical journals, and it's all referenced. So the patients should take this to their clinician and let their clinicians. Sometimes patients have to educate their doctors, and
Yes.
maybe not sometimes, many times. And so patients who are, undergoing surgery should be proactive. They need to educate themselves, and if needs be, educate their doctors. They are not passive passengers in this journey. They are participants in a teamwork. This is teamwork to get the best outcome for the patient.
And to that point, I mean, each individual knows their body better than your surgeon will ever know it, your doctor will ever know it. And so, and it's your body, it's your temple, it's your vessel. So the things you do and don't want going into that, and again, the type of perhaps side effects or long-term, hardcore trauma that you may have to overcome from the process. Some people don't want to go through that. So, as much as you do or don't want to do, I think should be a shared decision.
Yeah, a question I want to ask Ryan,
Mm-hmm.
because a patient asked me this question. And so the patient has a lump in the breast,
Mm-hmm.
and the surgeon wanted to do a biopsy
Sure.
to determine what it is, and then if it was malignant, to do a lumpectomy.
Mm-hmm.
Patient said she doesn't want that. She just wants the surgeon to cut out the mass without a biopsy. So I thought that was not a good idea, because not all while the mass may be malignant, not all masses are malignant. And
Correct.
that I think you need a biopsy before you actually do the definitive surgery. Would you agree with that?
I think it's important for a couple of reasons. And because, especially if you get a bigger biopsy, as the pathologist, we can do certain stains and markers, what type of tumor, what expression. And then what I don't like that happens in medicine is you get the biopsy, but then the surgical removal, if it is malignant, is oftentimes delayed for several weeks. I don't like the patient to have to wait in that window. If I were in charge for a day of hospital administration or surgical centers, I would say if you're going to schedule the patient for a biopsy, it may take the pathologist 1, 2, 3 days to get all the stains done, but the moment everything is complete, then schedule them the next day for the surgery. And that way you decrease the risk of the metastatic possibilities. But there are so many benign lesions in the body, especially the breast, fibroadenomas, fibrocystic disease, cysts, et cetera, et cetera. So I think, to put the mind at ease, sometimes getting that biopsy, you get the benign diagnosis, and then it's actually very calming to the immune system, because now you have something benign. So I know there's a lot of controversy, does biopsy cause spread or not? Well, it depends on those Velcro adhesion molecules and other things as well. And you can do some of the protocols that you've already mentioned, or some of the medications preoperatively. So I think knowing is half the battle. And I think if you don't know, then you don't want to let something malignant fester and stew and grow without knowing what it is and having the opportunity to treat and intervene.
We agree.
Yeah.
So should we see if Autumn has any questions for
Yeah,
us?
let me, I just want to, before she pops on here, let's, there may be some patients newly going through this process, and our heart goes out to you. Many of us, I don't think any of us know. I think we all know somebody going through this process. So I think that's critically important. And, what Dr. Marik shared tonight, it's always an evolving field. So keep that in mind. Stay engaged. Remember, it's your body, your decisions. I like that Paul brings up this perioperative window. I think we need to pay more attention to that. You know me, people are going to hear me say it a billion times. Get outside, get your sunshine, get your vitamin D, make your body healthy as much by lifestyle, like Dr. Marik said, diet, lifestyle. And a lot of these repurposed drugs are helpful for a lot of people. So don't manage this alone. There are a lot of good doctors still out there, and a lot of them that are independent. Dr. Marik and I were talking about this before. We both had our personal annuals yesterday and both had opposite experiences. One in the system, one out. But, there are a lot of good caring physicians out there. Just, find one. And with that, I'm sure we have 1,000 questions. So to your point,
So Ryan, just on that, before you do,
yeah,
one of the questions I get over and over and over again
yeah,
is, my oncologist not really interested in what I have to say. I'm looking for an integrative oncologist in my area. So what I say, and this actually does work, I say to them, go to Dr. Google and Google integrative clinicians in your area. So the patient was from Austin. So, Google integrative clinicians in Austin. And then what you do, you have a list of 10 or 15. You actually call each and every practice and ask them, do they treat patients with cancer, and engage in a conversation. And that's probably the best way to find a integrative clinician who will help them navigate this course.
And we're going to keep adding those to our trusted referral network as we can here at IMA as well. So I think that's, as we find them or as you find them, refer them to us and we'll put them in the network because everybody's looking. So that's a great point, Dr. Marik, that you bring up.
Yeah, patients should not be doing this on their own. They need the help, and it should be face-to-face. Telemedicine is fine, but I think having a face-to-face conversation with a physician who understands is really important.
I concur. So Autumn, probably a billion questions, so your turn. Go ahead.
Yeah, you have billions, but we'll try to get through them quickly. Dory asked, please speak to post-radiation care/prevention. I am 83 with stage 1 upper right lobe tumor, and I have 5 SBRT treatments for. But if one of you could please speak to post-radiation care and prevention.
Okay. Do you want to hit that one, Dr. Marik, or do you want me to go
you
first?
hit it, Brian.
I am not a big fan of radiation personally. My mom was back in the ICU 2 days ago because during her other ICU stay for sepsis from the chemo, they forgot to do the massage that they were doing on her arm because she had gotten radiation and ended up with lymphedema, a cyst that kept growing and then burst. Radiation causes a lot of fibrosis and scarring. Now, if you're going to do the radiation, many people know that I'm a big fan of red light therapy and red light devices. That will decrease scarring. So there's a lot of red light devices on the market. Some are great, some are bad, but if you can get one that will penetrate the tissues deeply, you can decrease the fibrosis and the scarring post-radiation and rev the mitochondrial activity, energy of the cells as well. So that's my 2 cents on radiation.
Yeah, my 2 cents is that, like Ryan, I'm not a big fan of radiation therapy. I think it causes a lot of complications. But I think there are specific indications in which it can be helpful.
Yeah, not every cancer, but some. And this is where doing the research is important. I agree.
So I think for some cancers, it can be helpful, but one has to be careful that it causes significant complications and can cause tissue necrosis. It can cause fibrosis. It can cause tissue damage. So I think nowadays they can target it much more specifically. So in specific situations, I think targeted radiotherapy is okay. But as a general rule, I'm not a big fan.
Mm-hmm.
Bob Isaacson asked, and we actually got a lot of questions. I know you guys touched on biopsies a bit, but just wanted to cover it one more. He asked, do biopsies pose an increased risk of metastases similar to surgery?
This is
The
a
answer is, I think, yes. I would assume yes.
My, my answer as a pathologist is in some cases, maybe in other cases, if the Velcro is still in place in the cancer, where the cells are sticking together with that adhesion molecule, then no. But you are opening up vascular channels. So there's always the small chance. There's about 50 papers out there that say yes, and there's many others that say no. Like my whole career as a pathologist was interpreting biopsies, and you can't treat what you don't find, and you can't find what you don't look for. So it's a conundrum. So
What I would say is that the risk is much higher with surgery than a biopsy, and it depends upon the size of the tumor and the type of biopsy. But I would still do a perioperative prophylactic protocol. What do you have to lose?
right.
You have nothing absolutely to lose. If these medications were toxic and had serious side effects, yeah, I could understand.
And
But they
somebody asks, do needle biopsies have the same risk? Well, small gauge needle is not as high of a risk because it's such a small tract. And then you do get scarring around that tract where the needle goes. And very rarely do we see in the surgical specimen after the needle biopsy, you'll see the fibrous scar from where the needle went in and out. I can say after 1.4 million biopsies I've seen in a career, very rarely have I seen tumor cells within that needle tract itself.
Yeah, but I think if you're doing a more aggressive biopsy,
Mm-hmm.
so most times the pathologist or the surgeon wants a reasonable piece or chunk of tumor so that they can do what Dr. Cole does, look for all these different biomarkers and receptors and whatever. So if it's a more invasive surgical procedure, I would say you've got nothing to lose.
Yeah,
Uh,
use the pre-biopsy, preoperative protocols.
Uh,
I don't like that. I don't like the word protocols. The guidelines or the guide ideas, not even guidelines, just the ideas Paul put forward.
Ideas. Another question that we got from Adam was, do you ever use ivermectin or mebendazole topically for skin cancer?
so that's a really interesting question. And I can tell you there are a lot of people doing this.
Mm-hmm.
There are a lot of people doing this, not just a few. I get these people, it's not the standard care for squamous cell or basal cell carcinoma. That's for sure. And if you look, we've outlined the standard treatment. I mean, for squamous cell, it's surgical excision. But I can tell you, hundreds of patients are using topical ivermectin to treat their skin cancer. And so I'm going to say something which some people are going to be alarmed by what I say, because what I say to these people is, why don't you mix it with DMSO? So DMSO is one of the things that I absolutely detest more than the devil. But the interesting thing about DMSO, which is an industrial solvent, it's an industrial solvent. It diffuses profoundly through the tissues and drags whatever molecule with it. So there is a study actually in patients with squamous carcinoma who were treated with a combination of DMSO and vitamin C and had a very good outcome, better than standard of care. So that's something to, I don't like DMSO, especially when given orally and for all kinds of nonsense. But it is an industrial solvent. So if you want to get a higher concentration in the tissue, if you mix the ivermectin with the DMSO, this is all theoretical. So let me say this. This is all theoretical. There's no published data, but patients will do what they want to do. And there are patients who are doing this.
Yeah. And DMSO plus ivermectin, yeah, it can penetrate more deeply into the tissues and have a positive anti-cancer effect. Some people will use even the traditional black salve, which, can look horrible while the lesion is healing. But there's so many, most people don't want a scar and a big surgery on their skin. There are some alternatives. Now, when I was a resident, I was doing all the analyses of the imiquimod studies, Aldera, for cancers. Well, the challenge with those, and this is, I think, the hypothetical challenge with even some of these topicals, certain skin cancers are skin deep. They're literally just on the surface and haven't penetrated and haven't gotten down to the vessels where they can spread yet. Other cancers are deeper or infiltrative or nodular, and that's the challenge with saying, well, it cleared up on the surface, but you may have tentacles going down, and what you're putting on the top may not get deep enough to get all those tentacles. Go ahead, Autumn.
Last question. Carrie Pine asked, Dr. Marik, do you have a ceiling for what a person's vitamin D levels should be, and what the level that they should no higher than? What's the level that they shouldn't be any higher than?
So that's a good question, and Ryan and I may disagree. So I think it depends on the situation. A vitamin D level in a healthy person, a patient with diabetes, a patient with rheumatoid arthritis, is very different to a patient who's being treated for a cancer. And so I think I would recommend, as a general rule, general patient, you want a level of around 50. I think around 50 is a good level. Now, if you have cancer, you want to push that higher, closer to 100. Some would even push it to 150. So I think it has to be individualized according to the patient. Now, if you're pushing if it's cancer and you're pushing the level to 150, there is a protocol called the Coimbra protocol, which is very smart, which in addition to measuring vitamin D, you measure parathormone level and calcium level, just to make sure that you're not overdoing it. So as a general rule, about 50. If you have cancer, 75 to 100. If you're actually going to push it much higher, then you need a more intensive program and you need to follow PTH and calcium levels. I don't know, how would you agree with that, Ryan?
Yeah, I agree. And from a physiology point of view, you're essentially saturated when you hit a level of 55. And you have to think of vitamin D like fuel in your car tank. You burn through it every day. And when your body is revved because it's fighting cancer or an infection, you're going to burn through it faster. So I think, to Dr. Marik's point, getting it above that 55 gives you a reserve tank, basically. But once you get in those higher levels, then you are leaching calcium into circulation, which poses risks. And then you do have to make sure you're doing magnesium as well as vitamin K2 and other things to keep that calcium from leaching from bone and or following that parathyroid hormone level as well as calcium level. So ideal is 55, but if you're fighting something, then make sure you're slightly higher than that. I agree.
Yeah, and you want to take K2. And the other point is that many of these diseases, patients have vitamin D receptor resistance. That's why you do need higher levels. But I think once you're pushing the level, I agree with Ryan, you need magnesium, you need K2, and you need to monitor these patients.
Yeah.
Before I move on to our closing announcements, is there anything that either of you would like to leave our audience with?
So I'm just going to say one thing. I think the environment of medicine is changing. And my strongest advice to patients is they need to be empowered. They need knowledge. They cannot just believe what they're being told, no matter what the disease is. There's enough information out there and they're reliable sources. So they need hope, they need knowledge, and they need teamwork. I think that's the trifecta to a good outcome. They can't do this alone. They need to find somebody to do this with. They need knowledge, and it applies to anything in life. And they need to be hopeful. And then I'm going to finish with that.
Yeah, I think that's well said, Dr. Marik. And look, a lot of people are going through this. Our heart goes out to you. There are a lot of options out there. Don't give up hope. And I think, continue to fight and to continue to use so many of these good things that are available. And remember, you are an individual And if somebody says, well, we do this, and you say, well, I don't want that, then remember what Dr. Marik just said. You're empowered to make a decision for your own body. So, keep fighting and stay positive through the process.
All right, well, I will move us over to our closing announcements.
Thank you, Dr. Marik. Thank you, Autumn.
Thank you both
so much.
Thanks.
We're going to keep these quick since we are already past the top of the hour, but if you want to keep learning, you can visit the IMA Cancer Resource Hub, which brings together free guides, tools, and support resources for patients, families, and healthcare professionals. You can visit imahealth.org/Cancer Resource Hub to explore more of these free resources for yourself. Also, we wanted to mention IMA Academy is now live at academy.imahealth.org. This is a major step in IMA's mission to restore trust in medicine by making high-quality, independent medical education easier to access and share. The Academy launched with more than 225 lectures, 130 hours of educational programming, and 56 physician and subject matter experts across dozens of specialties. It's built for healthcare professionals, patients, caregivers, and families. Don't forget, we also have CME opportunities available as well. Again, you can visit these wonderful resources at academy.imahealth.org. Well, before we close tonight's session, we wanted to share a message from our Chief Medical Officer and President, Dr. Joseph Farone, regarding an upcoming conference in Indonesia. Thank you again for watching, or if you're listening to this discussion, and we will see you all next week.
Hi, I'm Dr. Joseph Varone. I'm the President and Chief Medical Officer of the Independent Medical Alliance. Today, I want to talk to you about an upcoming meeting in Indonesia, the 30th Asia Pacific Symposium on Critical Care and Emergency Medicine. I have personally been involved in this Congress for the last 30 years, and I've been the co-chairman of this event for at least 25. This is an important event that now the Independent Medical Alliance is sponsoring and has been sponsoring even since the inception of our organization. The meeting deals primarily with acute and critical care medicine, and it's really this year we're going to be looking at what's been going on for the last 30 years of critical care medicine. What have we advanced? Did we learn anything from the pandemic? I mean, what's going on? In addition to that, the Independent Medical Alliance opens up the doors to all these international speakers. This Congress has speakers from many different countries around the world, and the fact that we can share with them some of our interesting topics as well as topics of debate is very important for the Independent Medical Alliance. I hope that some of you are able to attend either physically or virtually this 30th Asia Pacific Symposium on Critical Care and Emergency Medicine.